Indian perspective.
Thank you, Professor Namrata and Professor Rajesh. I'm indeed indebted to you for having included me in this AIOS webinar, which will have more of a educational as well as an academic outcome, I think, because we are all mostly are from institutional background, and I personally am very addicted and fond of academics and teaching, and so I would love to be in such symposiums if you further ever have, which you think I'll be meeting up to the standards of that symposium or the webinar, which is under your guidance. So I shall be talking about unmet needs for India for cases of neovascular AMD. Now one second. There is a, if you see AMD, it's a leading cause of blindness now as the aging has increased. Even in the COVID era, of course, some people who are old have not been able to survive, but most of our patients over 60, 65 are getting AMD, and it's been seen in even in younger patients. It's just like getting pre-senile cataract. So I'm getting in 50s also patients with neovascular AMD or its variant, the polypoidal choroidal vasculopathy. It's very difficult to differentiate. Of course, we've got a double edge sign, we've got a peak PED, and we've got polyps on ICG imaging, but they have some similarity. Maybe polypoidal choroidal vasculopathy, as Dr. Ko will tell in Singapore. Of course, we were not included in the Far East studies, India, and but now with Namrata and Rajesh there, we will probably get included in the PCV studies. I would definitely like to be one part of it. If you go through VRSI, I won't get included, so kindly include me separately. And 10 to 13% of adults you'll see over 65 are affected. There's a global prevalence of about 8.7%. And there is an increase of AMD will be 50% increase by 288 million. So there is a definite increase. All this slide is basically to tell you that two types of AMD: dry, which is actually 85%, but we see very little of it because patients don't have much visual loss. Only when they get into advanced AMD, a dry scar or a like a severe degenerative dead retina in the center do they come to us with dry. It's the 15% which is critical to us, which comes with very severe rapid fall of vision, which can be very sudden. As today, I got a patient. She was former Professor L.K. Bhutani, the director of AIMS in the 90s. If you remember, his wife suffered a neovascular AMD and came with a bleed today at 1 o'clock. So the bleed has come under the macula, and it's a very dense bleed which is covering the fovea to the superior arcade to the inferior arcade, and probably I'll have to put TPA in the subretinal space, which I told madam about it. And the cardiologist is in attendance. Her BP is high, so she has to be taken care of by the cardiology people first, and then probably we'll do the vitrectomy and the TPA injection subsequently. So these are the kind of problems which we have, the sudden onset division. So this is 90% of the visual loss. Leading cause of vision, 60 years. Prevalence is high in the industrialized country. We are also kind of industrialized. Indian studies underestimate prevalence of AMD because we don't have actual very good data on it. You need a dilated fundus examination, and you have to look for, you might not be able to pick up much on the color picture photograph, just like DR. You may need to do some special tests like OCT and all, which may not be possible in the community. And if you do a RAB survey or something, probably we'll need a handheld OCT to pick up the subretinal fluid. An INDIE study which was done and showed the prevalence of early AMD 1 and 2, which is as similar to a Western population, but grade 3 appear to be lower. All these studies will have fallacies because they're not actual big RAB surveys like DR has been done recently, and that had a 23.7% incidence. So Indian population currently is having a lot of AMD. We can do hospital-based tertiary level surveys, but that would only mean patients who come to the big hospitals. So it's important that we should have very trained personnel, not only for DR, but also what AMD looks like. So we have to have inexplained lipids, inexplained hemorrhages, inexplained fluid, and subretinal elevation of macula. If you have unexplained in that age group, over 55, 60, then you better think in terms of AMD, and the necessary investigations should be carried out. So the next but it's important to have these basic innovations, OCT, FFA. If ICG is possible, yes, FAF, of course, is very, very, very important. So you have to buy your equipment and then go to a retina specialist for visual gain after cataract surgery. Incidentally, if your dense cataract comes, you can't do the OCT also. Some of these patients may have AMD at the back, and there's a lack of awareness about public and ophthalmologists about AMD. They have more about diabetic retinopathy. So the mimickers of AMD, which can be MACTEL, type 2, PPC, which I just mentioned, it's in a big way in our country. Most of the cases I see in RP center, my field is confined to RP center only, and so I see a whole lot of Namrata, I see a whole lot of polypoidal choroidal vasculopathy at our center, and even today also in my OPD I found at least 2-3 cases, and they may not have the classical polyps, but they definitely have a double layer sign, and they have a thumb-like PD. So all these things are pointers that the patient is having a variant, whether it's some genetic, difference between the Western neovascular AMD or the Far East. Like India would be part of the Far East, so we are having similar to what Japan, China, and Singapore are having. So we get RAP, which is not so common, very uncommon. We get PEHCR, especially in wide field imaging and like the Optos, and we don't see much of it. AOFPD or adult onset foveal dystrophy is seen, not so uncommon, and we do mistake it for neovascular AMD, and we give anti-VEGFs. So this is a case of MACTEL, which we see the commonest among all those mimickers, and this is usually a beaten appearance with some pigmentation, and sometimes this capillaries are going at right angles. There's severe macular degeneration, a cavitation, and a CNVM can develop very often. MACTEL often develops a secondary CNVM. This is the way we see it. And when we see this CNVM, then we just, I think two OPDs back, we had a case. So we gave the anti-VEGF, telling the patient, of course, that the primary visual loss will not be, but the additional visual loss, which has occurred recently, will be taken care of. Then this is adult fovea vitelliform dystrophy. Vitelliform deposits under the retina. They look like as if there's a neovascular membrane and there's some fluid over there, but actually it's not that story. It's vitelliform deposit. It's like you have BEST. BEST is also BEST is also a disease where you have vitelliform deposits. So choroidal osteoma is something else, which is looks like a osseous transformation of the choroid, and this may be mimic something like a somebody who's not seen many neovascular AMD, especially for the learning residents. It's very good to know the differential diagnosis, and so it's important for them also to see these webinars, which are teaching webinars. And we would see that sometimes even a CNVM can develop in a case of choroidal osteoma also, the degenerative conditions also. Now, in the first line management of anti-VEGF era, the problem is that we don't know which injection to give. So that's an unmet need. The first thing I told you was that mimickers. So we've got to know what exactly neovascular AMD looks like. Second is how to treat. Should we give monthly standard monthly injections? Should we treat and extend? That means extend every 2 weeks after the first 3 injections loading dose, or should we treat and observe and treat as and when required? So PRN dosing as and when needed. That means when the fluid starts appearing again, then you inject. Or you give fixed monthly injection, or we treat, extend to 2 weeks. So till now, we haven't been able to kind of zoom in on which particular one entity is very far ahead. We just feel everybody's following his own regimen, and that's perfectly correct. Sometimes in the same OPD, I convert from one patient who's receiving PRN dosing to another patient who's receiving treat and extend. So it's basically how we do, and what would be the final outcome? We don't know. It's unmet need. The cost effectiveness also varies. Bevacizumab is slightly inferior to ranibizumab, but there are problems, problems of bevacizumab that they can be. Ranibizumab is not so cost effective as bevacizumab, and it's actually ranibizumab is more costly, but it has definitely superior gain in diabetic patients as well as neovascular AMD patients as compared to bevacizumab. But one second. Okay, anyway, there's the thing is for bevacizumab, there's one small drawback, not small drawback, that it can lead to, because we are counting What we'll have is single dose bevacizumab. That would be the ideal thing. If the DGCI, I think Dr. Professor Vaishali was also there in that meeting held 3-4 years back. The DGCI barely gave us permission to use bevacizumab, but the thing is, we are right now having multi-dose vials. Those multi-dose vials, you have to pull out injections and then give it. And those vials can be, 2 vials can be taken for fungal and bacterial, but all has a risk. And because those vials have to be used, they have to be kept in a sterile tray or a container and used within 24 to 48 hours. But the leftover can sometimes be accidentally used, or there can be contamination of the vial. So that is known. These contamination of the vials are well known, and hence bevacizumab is not a preferred drug to give in Indian conditions, because we talk about Indian conditions right now. We don't have single dose, which would be the ideal single dose bevacizumab. So, but you have razumab, but that's a biosimilar. So a lot of people use razumab. Ranibizumab, on the other hand, is a single dose, and even Eylea or aflibercept are single dose. Now, issues, what are the issues with anti-VEGF in our country? Compliance, frequent follow-up, monthly, near monthly, or how often do we follow up? Short duration of the effect. We've seen effect wearing off before 1 month. Sometimes the effect stays on. So it's varying, but it's shorter duration. So the patient has to come back again and again. Like every month, he has to report back. Even if it's aflibercept, often the patient has to come back in about 4 to 6 weeks latest. Because sometimes the neovascular AMD patients or a PCV patient, they can bleed also, especially the PCV patients. I've personally had patients in the COVID period. One patient who was a writer who bled in one eye, despite the fact that we were giving him the standard 4 to 6 week follow-up. We were giving him the fixed follow-ups. And 30% lose vision because by repeated injections, we actually cause a scar or a fibrosis in the macula. And the patient says, my central vision is gone. And so finally, it's low vision aids. Otherwise, receiving anti-VEGF, the patient is unhappy, but we can't do anything. The scar does form, the vascular response may be there, but the scar tissue formation is quite high. So we have this is a major unmet need. If you have less vision, the quality of life goes down. That's what's happening. The risk of infection also stays. You may cause a cataract because the needle tracks instead of pointing a needle towards the vitreous, you actually give it a little more anteriorly. So the lenses are swollen also, and they can literally enter the posterior, cause a huge rent in the posterior capsule and enter the substance of the lens. And then the patient needs to get a surgery for cataract. The cataract surgeon say 4 to 6 weeks later, because I don't do cataract surgery and many of my colleagues don't do. But I'll say to Namrata, please do it. She said 4 to 6 weeks later. Rajesh, please do it. No, 4 to 6 weeks later. Let that wound, which is causing the cataract, heal. And thromboembolic adverse events, you all know, they do occur. Though we may say that it's very safe, I always give it. I have the biggest VRSI surgeon here. The VRSI boasts like that. No, but it happens. It happens. You can't believe anybody. I've seen it myself happening in my own cases after a week, 10 days. So the burden to the patient, these repeated injections, economic burden, the social burden, traveling, all that stuff. He wants to discontinue. He gets into kind of a depression as they're getting into depression due to the COVID era. Now there's another new anti-VEGF which is now come in, which is a little very interestingly very longer acting, and they offer extended VEGF inhibition. It's also known as Beovu or Beobu. So you can pronounce it as you feel like, and it's a humanized single chain. Instead of a double chain, it's a single chain antibody fragment. It inhibits all isoforms of VEGF-A. So it's not VEGF A 170 or 180 isoform, it's entire isoforms. So molecular weight is very tiny, so it enters the retina very quickly. It's even smaller molecule than the ranibizumab. Ranibizumab is about 48 kilodaltons. This is 26 kilodaltons. So it's a tiny fragment. We want the fragment to enter the retina and come into the subretinal space and act on the neovascular membrane effectively and for a longer duration. So it stays in the body also for a long time. So there's 3 monthly dosing. So Hawk and Harrier, the main studies which showed that brolucizumab was non-inferior to aflibercept, which was a gold standard in the form of that aflibercept was being thought as the best drug intravitreal injection for anti-VEGF for neovascular AMD or so Rolostuzumab, we can't do everything Western all the time, so it's important. Rolostuzumab can be given as 12 monthly, that is 12 weekly, that is 3 monthly, or a 2 monthly, bi-monthly, or a tri-monthly dosing. And that's what they showed, that the outcome in this Hawk and Harrier was very interesting. It was a potent drying agent. But there have been some reports from American Society of Retina Specialists of inflammation following rolostuzumab administration. In addition to cases of mild to moderate intraocular inflammation, which was about 4%, 14 cases had occlusive vasculitis. So that was something which was something to look up to. And since then, there has been a, though of course it's FDA approved, but still we'll have to be under a little caution. And besides this, there can be other longer acting delivery agents, because patients don't, the burden on them, also the COVID period, they don't want to come back again and again to the hospital for injections and expose them to infections and all that. We would like to give longer injections so that they can stay away from us, but they will be costly also. The rolostuzumab will also be costly. I think, I don't know the cost, but it's definitely going to be more than PDT maybe, or somewhere around PDT, or maybe more than PDT. Is costing around 60,000. So how many patients would afford that? Because many patients in our place just afford Avastin. So sustained delivery preparation, this has PDS. It's like a port delivery system, that just like you had the Ganciclovir intraocular device for CMV retinitis. So same way, there's a biodegradable, non-biodegradable, stitch it to the sclera and keep the port there, and which can be refilled. It's in the office. You refill it, just go to the office, the hospital. The office is USA, but in India it's the hospital and the OT. You will we refill it in our OR. But how much we'll get to know, this ladder study is on. If it's safe, then probably it can be an alternative. The sustained drug delivery. The wound has to be, of course, kept very clean, and you'll have to take some antibody drops. Some newer novel approaches, which I feel have great importance. And Povista didn't work. It was supposed to be, very effective. It's a bimanual to a twin pronged action. And faricimab has now come in, and faricimab is actually anti-angiogenic. It inhibits the angiogenesis through Ang2 inhibition, and it is anti-VEGF. So it's actually combining the two anti-angiogenic effect and the anti-VEGF effect. And faricimab may be a drug of the future. Only time will tell us. It's a single molecule, two targets. Two targets mean the anti-Ang and the anti-VEGF. By maybe combining the two, we may get less fibrosis. And that fibrosis, if it reduces, scar formation reduces, a big boon, and it'll be heaven for the retina specialists. Gene therapy may come in, that you have subretinal delivery of some modified genes, or intravitreal delivery. So we'll have some spine needles. We do vitrectomy. The retina surgeon does the vitrectomy and puts the subretinal gene, which is going to inhibit the fibrovascular proliferation, which is occurring in the subretinal space. This is really exciting. Targeted immunotherapy also to kill the cells which are responsible for this neovascular membranes. Stem cell therapy is there, but I don't think it's worked. We've done some work at RP Center for dry AMD. It didn't show much of improvement. So wet AMD, because the neovascularization, I don't know how far it's got to inhibit the new vessels. So faricimab and these new gene therapies would definitely have a role. And these unmet needs would be probably met. How much I can't say, but to some extent. So what present date happens is the neovascular AMD converts to the scar. This is what we don't want. The PCV is something I'm going to tell you towards the end, that this is a big problem which we have in our country, and it's a variant of neovascular AMD. It has more chances of bleeding, and it is less effective with anti-VEGF. So we have to usually resort to very strong anti-VEGFs like Eylea or ranibizumab. And what you get is aneurysmal dilatations in the outer branching network of the neovascular network, the polyps. And the choroids are thickened. That's why it's called pachychoroid spectrum. And the PDs are tiny and thumb-like, and they go like sharp peak PDs. There's often maybe absence of drusen, and you may have a double layer sign where the fibrovascular proliferation occurs, the branching vascular network, the BVN. It has an Asian ancestry. It's not reported much in the West, and we see a lot in India. At least we see it at our center. I can't comment on any other society or a center. And I see it, of course, from ages ranging from 30 to 40 to going up to 60 to 70. Even the old age patients, very old patients of neovascular, we are continuing with that. So it's some kind of variant, but it's because the findings are totally different. So these are the so many collection of pictures which I have of various imaging modalities. This is a branching vascular network, and these are the polyps I have done. So I just bought some, and this is a PED, like a thing thumb like PED, which is sharp pointed, and this double layer sign over here because of branching vascular network. And this is the branching vascular network new vessels which are there. This is one patient, and this is another patient with a polyp hemorrhage around it. This is a polyp on ICG imaging. And this ICG actually should be done with the fluorescein angiography. And for that, you need the spectralis. So if you don't have it, then you should get it done from somewhere. And I would recommend that ICG should be given importance whenever a patient with suspected unexplained hemorrhages in the macula, exudates come in the macula, and a patient has drop of vision and maybe having history of central serous choroidopathy. In such patients, of course, OCTA would be definitely required, but in the baseline and maybe 3-4 monthly follow-up, the ICG would be required. We should look for these polyps because if the polyps are there, there's a higher chance of a bleed. That's what I think. So when I have these patients, then sometimes we have to give more potent anti-VEGF agents, and I sometimes have to resort to reduced fluence or half fluence PDT for such patients. So we see a patient here who's probably had uh, CSR-like lesion before, and now he's developed some hemorrhagic, hyperfluorescent lesion on FA. On ICG on the same patient, you can see the polyp over here, and the sharp PED corresponds to the actually the polyps. The polyps grow here on the inside surface of the PED, and this is the branching vascular network, which is actually like a double layering of the Brooks membrane, or it's a that's what they say, and they say the vessels grow under it. So branching vascular network with the polyps, with the sharp peak PED, with subretinal fluid is all classic with absence of brucin, is classic of a branching polypoidal choroidal vascular. This is a patient who received the injection 3 monthly loading doses as we give. At RP center, we give monthly loading doses 3, and then we see the patient's response. If it's good, often it's good. We tell him to hang on. We give him a treat and extend policy. So for PCV, so I think probably we need to write on this. Anti-VEGF and PCV, every study we know, we combine the two with the ranibizumab and PDT. PDT is one area where I feel PDT has a role in PCV because PDT has a role in CSC. So CSC works, amazing results of CSC patients, chronic CSC patients with PDT, reduced fluence, not full fluence. And today I had a case of hemangioma, so I recommended him. It come from Ajmer, so I recommended him full fluence double dose. But full fluence you reserve for center. Various societies and centers may think differently, but I'd like to give double dose, like I told that man. But in PCV, I'll give reduced fluence because there's a choroidal element of choroidal vascular ischemia, and patient may lose vision. I've seen some of patients, 1 or 2 patients who had poor vision gain after giving full fluence. So we, since time immemorial, 2-3 years, we've stopped giving full fluence, and it causes regression of polyps. I think if it's got a chronic PCV, it's good to take up for PDT because this chronic you can't keep injecting. It may be causing more scarring. So when you cause more scarring, there's more problems. The Planet study improved one, or just want to do something else. They use aflibercept instead of ranibizumab. So actually, we've been basically we've got two choices right now. We've got ranibizumab, aflibercept, and of course we've got not 3 choices. We have bevacizumab also. It improves visual acuity in PC patients without the need for PDT. And this the basic show aflibercept was very effective. We didn't need PDT. I think PDT is required. When the patient gets very chronic, he's taken 8 or 10 injections. There's still presence of subretinal fluid, and Octa shows new vessels. I'm giving a lot of importance to Octa nowadays for follow-up of neovascular AMD patients and follow-up of idiopathic CNV patients, for follow-up of PCV patients. I've seen patients even with no fluid, but the presence of new vessels on Octa, they bleed. I saw 2 patients in the last 6 months, and I am an active working ophthalmologist right now at RP Center. I've seen 2 patients who didn't have fluid, and like to ask Professor Vishali's opinion, who had new vessels on the Octa, but had no subretinal fluid, bled. So what I'm trying to say is it that the subretinal fluid may or may not be there, just the Octa? What kind of extra study can we do, imaging study can we be done to know that which patient is a potent bleeder? future bleeder. So that's what we want to do. Everest 2 was also the superiority of the combination or ranibizumab monotherapy. And with both ranibizumab and PDT complementing, this is a complement, they found lesser injection. So modified injection, if you get a bleeding, what I do in the last 1 minute, I'm going to tell you that we give TPA, like today, LK Botani, our former director's wife has come. So we give recombinant TPA with bevacizumab and air. And this is the blood which is collected in a PCVI. And so you see the blood may be there, but as long as the fovea is involved, you got to do it. It may not be so much, but we get sometimes massive bleeds also going into the arcade to arcade. So if you don't get it even till the arcade to arcade, as long as the fovea is involved and it's an elevated blood, it's not a thin layer of blood. If it's a thin layer of blood, you see how elevated it is. Yeah, there's PD over here. So the IOCT tells me exactly where to put the needle. This is the IOCT device which is there on the Zeiss. So I use this 41 gauge translocation needle, go close to the disc and inject the recombinant TPA, the Vastin. Some blood does come out, the subretinal blood, and I inject air. So this is the technique I've been using for the last now 2 years. We got a couple of publications on it because many people are already doing it, and so such publication. But we have 2-3 publications. We are writing another one which is going to be a little better in the sense that we're going to tell a few modifications we've done in the injection, and that probably will help. So this is the kind of picture, and I can tell you the miracle is the next day morning there's no blood in the macula. The blood is lying at the bottom, the subretinal space. So this is something we've done a lot, and we've got. I mean, I've done a lot, and I've got about 2 years experience at RP Center. RP Center has been like a mother god to me, and all through my MD, and my residency, and my senior residency, my faculty, this place has been sheltering me from all kinds of problems, and I keep doing my work. That's what I like to. And the unmet needs from patient's perspective is that this high burden transportation causes issues, not so much in India, but there are. Of course, in the West it is. But why should we talk of the West? It's time consuming that now with the COVID period, you'll have to first get few patients, you'll have to have a triaging, the patients who are more serious. Like a neovascular AMD, yes, like this symposium or webinar. I'd rather call it a symposium, it's teaching. So we'd rather we'll call a neovascular AMD or PCV case, then we give him antibiotics, tell him to change clothes completely, wear a mask, and his mask, he goes in the you also wear all your this thing, full PPEs required, a full gown, mask, cap, and make sure the injection is given in a most highly sterile condition. We give sodium hypochlorite fogging, and we also do bacillocid spray of all our OT areas as well as non-OT areas every 4 hourly. So with the COVID era, we have been very, very careful because not only the infection, but the COVID infection also is some patients discontinue because the travel is too long. It's of course economic reasons also when it comes too long. So maybe I'm sure doctors are present close by who can give the injection. They don't need to come all the way to large cities. Dissatisfaction with the benefits because as the vessels of new vessels matured, they don't respond to anti-VEGF. That was the reason why they use that Fovista. Fovista would strip the endothelium of its the complete blood vessel. Only the bare endothelium was left. If the bare endothelium is left of the new vessels, only then the anti-VEGF acts best. So anti-VEGF acts best in the first 3 injections. Afterwards, if it's there, it's going to act, the vessels will mature. Then only what will act is probably the PDT. So sometimes we are fooling ourselves. We don't know how much, at what stage we're going to start fooling the patient and ourselves. But that's the only way we have. So it's a major unmet need. The dissatisfaction with the surgeon and with the patient. And the burden of follow-up travel. It's not easy to come to a hospital or a center and keep sitting there for hours and then getting a turn and then going back. Today I was asking one of my patients, how long does it take to get back to work after an anti-VEGF injection? He's about 25, he says 1 week. After the injection, it takes you 1 week to literally feel that you are back to normal. So it's 1 week gone. It's working hours, number of working hours. The patient lives are preoccupied by frequent clinic visits. So we need longer acting, safer, less travel, less COVID. It should not be that we have to, and this is the low vision aid clinic in the retina unit which we have. It's not the main RP center retina unit. This is which I have it in my area, in my retinal lab area, and here we do all kinds of rehabilitation, low vision aids. And often these patients in the end require this. So this is also an unmet need which I feel needs to be developed further, and some symposium where we get these people also on to tell us what kind of visual aids can we give to the patient with neovascular AMD and central visual loss. I would request Professor Namrata and Professor Rajesh, who are coordinating this symposium, very nice symposium, and thank you very much for having thought of including me, because thank you very much.
Thank you, sir, for that excellent overview and for insights into ARMD. And I'm sure it was so well and comprehensively covered. Even I'm not a retina person, but I could also understand everything.
We all
So
learned from the same institution.
yes, sir. So even I could follow it